Unsullied by us humans, sex is a very good part of human life.
We live our lives in a great deal of hypocrisy, telling our children to do one thing while we do something else.
The quest for control. We all would love it if our lives were a bit more controllable.
Discussions within the Christian community about these questions will be primary for the survival of the Christian community.
Now, my task is not to answer any questions, but just to raise them, to sort of whet your bioethical appetite from personal experiences. As a physician, a pastor, and as the director in Dallas of the Christian Medical and Dental Society, all of these issues, virtually all of them, have been part of my life for the last 2 decades. Now, it has been my wonderful, wonderful opportunity to teach the OBGYN residents at Baylor Hospital a series on ethics. Now, Baylor Hospital in Dallas is where I practiced for those years, and we have lived there. Back when I was in residency, there was no ethics course. There was no CME requirement for annual updating in ethics. I think we're coming a long way. Well, during these sessions with the residents, obviously we come up with some interesting things, but we try to discuss the historical ethical views, the various systems and principles, learning the vocabulary and paradigms and things that they need to know for meaningful participation in the ethical arena. In one of our meetings this past year, one of the third-year residents presented an interesting case, an actual case that occurred at Baylor. And I want to relate it to you as we start our thinking in some very practical case situations. This was a young married woman that presented at term in labor with a third child. Now, that wouldn't seem particularly unusual, except for the interesting collection of family in the labor room. In addition to the husband and the laboring mother and the laboring mother's mother, we had the baby's father, which was the mother's stepfather. She had been inseminated by intrauterine insemination, artificial insemination, because the patient's mother had been surgically sterilized. So she was a traditional surrogate about to deliver her stepsister or stepbrother. What do you think? Regardless of your initial reaction, or even your considered opinion, the key question for this weekend is why? Why do you think that? What are the principles, the ethical steps, the moral paradigm that you employed to reach your decision? In these days of rapid medical advance, we need clear thinking to answer these very practical and complex questions. Preferably, we can arrive at a preemptive ethical stance and avoid the retrospective question of whether or not any given procedure is right, moral, or ethical. Now, in preparation for this address, I asked a number of the local physicians in Dallas, has an ethicist ever helped you to make a difficult clinical decision? 100% answered with an emphatic no. You see, that's very sad. We must make this conference, these discussions, practical and applicable to the dilemmas of life. As a board-certified OB-GYN who specialized in infertility before it was a specialty, virtually all these things pertain to my practice. I was in medical school when the Roe versus Wade decision came down and dramatically changed the direction of our culture and its views on life in the abortion controversy. The sexual revolution and STDs were exploding across the consciousness of America. Herpes became epidemic. Human papillomavirus linked with cervical cancer. The elusive chlamydia and its connection with infertility. These are things that were just unfolding. And then came HIV, perhaps the most frightening diagnosis since the plague, and all the issues pertinent to its spread and its treatment. And now, with HIV spreading throughout our population with women, pregnant women, and their offspring, we face the ethical ramifications of treating these patients without knowing, without any good human studies, as to what the effects of those treatments will be on the offspring. Are we facing, in 20 years from now, what we face with thalidomide, what we face with diethylstilbestrol? We simply don't know. And what are the ethics of not treating? When I was in residency, that was the time of the first test tube baby. So pregnancy, conception, family planning all became daily features of my life as a doctor, while the controversies in Christendom grew and became increasingly heated. Can Christians use contraception? Can one hold a high view of the sanctity of human life and use contraceptive devices or methods? And if so, which ones? And what about these high-tech procedures that we'll be talking about? Hardly a day in practice went by without some of these issues surfacing, and the camps now are deeply polarized, firmly entrenched, and armed to the teeth with the authoritative word. And what's your position? What are the biblical or moral or ethical principles that you use to arrive at your stance? Well, let's get practical. When it comes to the abortion issue, I must tell you of a patient that I had named Nanette. Now, I took care of her probably 15 years ago, but it seems like it was just yesterday. When she first came to my office, she was a newlywed, probably 28, 29 years of age, and she came in to discuss future pregnancies and her health condition. She had had a heart valve replaced some 15 years prior to the time of first seeing me, and valve surgery, of course, has improved considerably since that time, but the valve that she had was functioning poorly, with no hope of improvement short of replacement. I agreed with her cardiologist that she was not a good candidate for pregnancy, that the stress of increased blood volume and all the changes associated with normal pregnancy might prove more than her heart could handle. In short, pregnancy could be life-threatening for Nanette. The next time I saw her, several months down the road, she was a few weeks pregnant and in trouble already. Old artificial mechanical heart valves are not well suited to pregnancy. And the changes in blood clotting make these pregnancies very treacherous under the best of circumstances. Now, back in those days, using anticoagulants in early pregnancy was a total mystery. We really didn't understand how great the risk was of causing deformities, particularly limb deformities, but we knew that if the mother clotted and stroked, that we could risk losing them both. Many of her friends and her friends' physicians had advised her for abortion, but she being a very strong Christian woman, I knew that wasn't going to be an issue. So her cardiologist and I carefully nursed Nanette through her pregnancy. Crisis by crisis, hospitalization by hospitalization, in and out of cardiac failure, fluid imbalance, clotting emergencies. Finally, at 35 weeks of pregnancy, about 5 weeks short of term, which even back in those days wasn't too bad in the neonatal realm, Nanette came again to labor and delivery in early heart failure. Now, our medical staff swarmed over her, as is our wont, and got her stabilized. Shortly thereafter, we prepared and did an operative delivery, and the C-section delivered just a beautiful, healthy baby girl, all limbs intact. Now, for those of you familiar with the cardiovascular changes in pregnancy, you realize that the body has months to adapt to those increases in blood volume and weight and cardiac stress. But with delivery, the changes are fairly dramatic in the opposite direction. And though Nanette was being carefully monitored in intensive care, she crashed on the third day. The valve function diminished dramatically, and the cardiothoracic team decided that her only hope for survival was emergency valve replacement. We took her to surgery shortly thereafter, and as we moved her to the operating table, I remember her eyes as she looked at me and said, "Dr. Bill, I'm scared." Well, I stayed and watched, and when they removed the old valve, the opening in the valve was no bigger than a straw. It was amazing. And they put in the nice new valve, and it looked great. But when it was time to come off the pump, that heart wouldn't beat. The extensive and heroic efforts to resuscitate her were to no avail, and Nanette was pronounced dead. That pregnancy cost her life. We must remember that this temporal life is very fragile, and that pregnancy, even in this country where we have all of the resources, is not without risk. But there were several other cases that were life and death circumstances in pregnancy. We discussed one of those earlier with the medical students. And I say that just because I often hear people say in the abortion controversy, the life of the mother is never at risk. They're wrong. We need to be careful. because there are those rare cases where, in fact, the life of the mother is at risk, and in fact, all pregnancies have some risk. Now, what about the abnormal pregnancies, those with the genetic abnormalities or anatomic developmental problems that will affect the so-called quality of life? Here, at times, medical personnel reveal their bias. I consulted on a case of a woman who's discovered to be carrying a child with Down syndrome and an omphalocele. Now, that's a rather dramatic condition where much of the abdominal contents develop outside the body and stay there. She was told by her physician that the child would be a vegetable and never capable of any human response, and thus she should terminate her pregnancy. Now, I'm not suggesting to you that raising a child with Down syndrome is ever easy or simple. It's just impossible to predict how the baby would do, and the anatomy problem is surgically correctable. Decisions of this magnitude must be based on accurate information, at least to the extent that such information can be known. See, doctors can give bad advice based on personal opinion and bias. Do we treat genetic developmental abnormalities by eliminating the patient? I still receive calls even now, several years out of medical practice, about ectopic pregnancies. Those are tubal pregnancies, pregnancies that implant outside the uterus. Doctors have advised surgery to the patient or whatever to remove the pregnancy, and the mother is torn about the implications of this procedure being an abortion. In fact, some well-meaning pastoral advisors have added to the problem by suggesting that the baby can be moved or that it might migrate and be all right. At this moment, we have no such technology. The ectopic pregnancy still represents a great risk to the mother's life. In fact, women still die in America today because of undiagnosed ectopic pregnancies that rupture and the mother bleeds to death before she can get to surgical therapy. We must be accurate in our understanding and accurate in our advice if we're going to tell people what to do in the medical arena. Our zeal for the life of the baby may require realistic consideration for the life of the mother. You see, sometimes pastors and well-meaning friends can give bad advice based on wrong information, faulty understanding. Well, let's now consider the rapidly expanding horizon of infertility diagnosis and treatment, the assisted reproductive technologies. We live in a very exciting time. As I was telling the students earlier, Clomid was about our entire armamentarium for treating infertility. We only had one drug, we used it liberally. But now, with the micromanipulative techniques, you can take a single sperm and a single egg, and there's a reasonable chance for fertilization. It's amazing. But a caution. Because we can do something does not mean that we should do something. Each medical procedure must pass through the grid of theologically sound, moral, and ethical thinking. With each advance comes a commensurate responsibility to use or not use the technology wisely. Now, probably some here, would argue that no such procedures should be employed, that God has closed the womb and he can open it whenever he wants, without anyone's help, that doctors are playing God. Others argue that we treat cancer with chemotherapy, infections with antibiotics, diabetes with insulin. Why can we not treat infertility with appropriate measures? In fact, sometimes the treatment is simple antibiotics or hormone adjustment or perhaps a surgical opening of something that's blocked. Proper diagnosis is critical in the decision-making process for both the doctor and the patient. What about the really controversial issues like donor insemination or the post-mortem sperm collection that you probably read about in the paper? Surrogacy, cryopreservation, the freezing of embryos, selective reduction for high-order multiples. Are there any limits? Does anything go? Now we reach the crux of the matter. How do we decide? What are the principles or paradigms that apply to the ever-expanding scientific horizon? Can we even address spiritual matters outside the faith community? Are there even right answers? We need to recognize that we live in a day and a culture where many do not have as a presupposition that there is a right answer. Many have accepted the premise that the only thing you can truly know is what can be scientifically tested, repeated, and proved. Anything else can't be known, so there's no absolute truth, only opinion, perspective, or paradigm. And thus Christian viewpoints, faith-based viewpoints, have become irrelevant to the marketplace. of opinion and debate. They've become privatized as separate, non-intellectual sphere. This is dangerous. We must be ready intellectually to give a defense. We're to love God with our mind as well. We must be competent and articulate in our area of expertise, whether that's medicine, philosophy, or ethics. Ultimately, many of these particular issues distill down to our understanding of personhood, true humanity, marriage, family. We must diligently seek the right answers, diligently seek the truth. And I'm reminded of another case of a 30-year-old patient who'd experienced premature menopause. Again, not common, but certainly a situation familiar with most of the primary care physicians. This woman had not achieved pregnancy before she ceased ovulating. So she had eggs donated from her sister and was inseminated in vitro with her own husband's sperm, and then the embryo was reimplanted into her uterus with full hormonal support. In this particular case, cryopreservation was also used since the first cycle was unsuccessful, and she was successful and delivered healthy infants from frozen embryos. Now, does this represent a heroic, loving gift on the part of her sister? Or is it a violation of scriptural one-flesh principle and an outside-of-the-marriage offspring? How do you see it? And why do you construct your thinking that way? Sadly, many people are intellectually lazy and even gullible. They're content to have someone else do the thinking, and then they will echo that opinion. Give me an expert that can tell me what to think in 25 words or less. And so it goes. We become like lemmings in the religious sphere. One says something with credentials and authority, and we all parrot it without searching the scriptures to see if it's so. Confidence sometimes conceals ignorance. Sometimes we are far more sure than right. Can we answer the question as to when individual, unique human life begins? Personhood, origin of the soul. Can we address those? People that are using terms like pre-embryo or products of conception, and what they mean is living tissue without humanity or without personhood. We need to understand the biological processes so that we can meet each issue precisely. Can you argue theologically, philosophically, bringing into the discussion what is current, what is pertinent? Then, having done that, you can address the issues of frozen egg, frozen sperm, frozen embryo, selective reduction, pregnancy termination for a non-viable pregnancy versus a genetic abnormality versus inconvenience. Then we can talk about genetic engineering. Then we can talk about human cloning, because we've laid the framework of philosophy and theology and putting them together in such a way that we can speak with precision. So in conclusion, I too, having a pastoral background, would like to challenge you. But my challenge is that throughout this conference, that you listen, you learn, you think, you analyze, and you pray for wisdom and discernment as we struggle with these issues. There are godly, committed men and women of integrity here that differ on many of these controversial issues. Strive to understand and hone your thinking. Be an expert in your field. Do good science and impact your arena for Christ, so that while we are pressing on with academic zeal, we may be diligent to love one another, because that's how the world will know that we're Christ's disciples. The scientific world will watch. They'll listen to see if our reasoning is sound. But what will be the lasting impact of our time together? Will people be drawn to the truth, the way, the truth, the life that's in Jesus Christ? Thank you.
John had asked me to speak a little bit about my own personal experience. Also, he asked me, what do infertility patients experience and what do you as a nurse practitioner dealing with them experience? I work in a reproductive endocrine center, which is the infertility specialists, the ones that do the IVF procedures and those, and so we are impacting on these multitude of dilemmas every day. I first became acquainted with infertility about 12 years ago as a patient at the center being diagnosed with severe endometriosis. I have undergone multiple surgeries, an in vitro fertilization attempt, a gamete interfallopian transfer procedure, all unsuccessfully in my attempt to become pregnant. But thankfully, we have been able to adopt 2 children. Obviously, I have personally and as a couple wrestled and faced the ethical and moral decisions that must be made when considering utilization of the assisted reproductive technologies. I can't say I understand exactly what our patients are going through, but I certainly have experienced similar feelings and frustrations. A few statistics may lay the groundwork as for a foundation for the rest of this conference. Infertility is defined as the inability to achieve a pregnancy after 1 year of unprotected intercourse, after 6 months if the woman is over age 35, or the inability to carry a pregnancy to live birth, which many times is an aspect that people don't appreciate as also very much of a struggle and a part of infertility. Evaluation of the infertile couple must focus on both partners. 40% of the time, it's a male factor problem. 40% of the time, it's female. 15%, it's usually a combined male-female problem. 5% is the unexplained infertility. These are the people that are actually the ones when people say, just adopt, you'll get pregnant. Many times they do. It's because it's an unexplained problem. We don't know why they were not able to achieve a pregnancy on their own. To evaluate only one partner, even when the problem seems apparent, is quite inappropriate due to the high incidences of multiple problems. It's quite frustrating to have a couple referred to us where the woman has gone through the full infertility evaluation, including a laparoscopy surgery, and no one has ever evaluated the husband as far as with the semen analysis. Infertility affects 1 out of every 6 couples in the United States. So again, I think you can realize and appreciate what a prevalent problem this is. Primary infertility occurs in couples who have never been able to become pregnant or achieved a pregnancy. Secondary infertility occurs after one partner has previously achieved a pregnancy. These are the couples that many times don't receive a lot of empathy from church members or from family or friends, because after all, they already have one child at home. But these are also the couples that are so driven because they know what a wonderful experience it is to parent. They know that their bodies have done this before. They are so frustrated at not being able to make their bodies make eggs or make sperm to be able to accomplish this for their second or their third child. So again, of being able to validate with them the true frustration that they understand and not of a sense of false guilt for that. Infertility is truly a crisis for many people, for many couples. It can affect all areas of their lives: social, family, marriage relationships, their employment, as if they may have to come to the center frequently for ultrasounds or blood test examinations, their own physical health, and their faith in God. It may represent the first obstacle in the individual or couple who have not been able to overcome in fulfilling their lifelong dreams. This leaves them feeling very vulnerable, helpless, and often angry. It represents many losses that need to be identified, validated, and grieved by each couple. Pat Johnston, in her book, Taking Charge of Infertility, describes some of the losses that these couples experience, I think, very succinctly. The control over many aspects of their lives. And we see this again as very motivated people who are just used to being able to put enough effort into any program and make it work. For women who are waiting, kind of putting family on hold to become the full law partner, and that they're used to, again, being able to make anything become accomplished if they just try hard enough, can't accomplish this most important goal. Loss of the individual genetic continuity linking past and future. Loss of the joint conception of a child with one's partner, loss of the physical satisfaction of pregnancy and birth, loss of the emotional gratifications of pregnancy and birth, loss of the opportunity to parent. These are intangible losses, often totally unrecognized by family and friends. If a stillbirth occurs, there's a funeral, there's flowers that are sent by family and friends, and the couple have a lot of people to rally around them and grieve their loss. But miscarriages or negative pregnancy tests are often losses that are not acknowledged and grieved, often just only by the couples themselves. Family and friends not familiar with infertility losses often make very hurtful comments in their ignorance. I will provide a more thorough list of helpful resources, including a sheet on what not to say and things that you can do to help infertility couples in the conference syllabus that was going to be published later. I encourage couples to copy, especially that sheet. That's kind of the things that you can do to help and things not to say, and send it to family and friends to help educate them and elicit helpful support. The office staff may be the only other people who know of the couple's infertility struggle. For many couples, this is a very private issue, and not one that they would easily divulge with other friends. Nurses and the office receptionists often receive the brunt of some of that frustration and anger. Patients often equate the physician as the enabler of their dreams, and therefore they don't want to risk alienating them with their anger. Thankfully, though, we're also usually one of the first to receive hugs from our patients. The fast pace, the demands for flawless work as far as working with different stimulation protocols, ever-changing protocols, turns most of the nursing staff into obsessive-compulsive employees. These expectations, plus working with often very motivated, demanding, resourceful, sometimes angry patients, all attribute to the burnout of reproductive and endocrine nurses. The majority of nurses who work in this field move on to another specialty after 5 to 10 years. The technology grows so rapidly and the state of change so prevalent that one either finds it tremendously exciting or extremely frustrating. A California colleague shared a story of how motivated a couple can be, in that this couple navigated their way to the clinic on time for their in vitro fertilization egg retrieval the morning after the devastating earthquake in Los Angeles several years ago. The staff were home taking care of their families and what was left of their homes, and yet obviously this couple expected that everyone would be at the clinic to complete their egg retrieval. My role as a nurse practitioner also includes being a consumer advocate, counselor, part of it ethicist, and also spiritual advisor. Probably 60% of my time is spent attending to the emotional aspects of infertility. Thankfully, I work in an office that values that time. Thus, my appointments are scheduled 30 minutes apart. The exam may take only 5 minutes, but the rest of the time is an opportunity to reassess the treatment plan and to offer emotional support. I try to encourage each couple to take inventory and decide how much money, time, effort, physical discomfort, and emotional distress they are willing to endure in their quest for a pregnancy. This enables them to develop their treatment plan and to restore some of the control in their lives. Again, I'm seeing so much of how infertility takes away that control of being able to plan and have our families as we had wished. My aim, when appropriate, is to leave each patient encounter with a hug, because I want them to know that I care about them on an emotional level as well. As mentioned previously, infertility often leaves couples feeling out of control of their lives. They're unable to make their bodies produce the oocytes or the sperm to fulfill that lifelong dream. Nurses and physicians also feel the frustration of not being able to make a pregnancy happen. We are humbled every day with the fact of who is really in charge of every conception. I strive to empower couples to grieve their losses and make decisions regarding their treatment plan to hopefully help them grow as a couple to a higher plane in their relationship. Many couples have grown so much closer during their infertility journey that their decision to pursue child-free living becomes a solace. I'm just as excited to see pictures of a brand new sailboat as I am for other couples who have brought in a baby picture. One of my roles is to coordinate our male factor infertility program. This encompasses intrauterine inseminations with husband sperm, as well as the option of utilizing donor sperm. I often recognize gender differences in grieving and in coping with infertility. Women tend to be verbal, sifting through decisions as they discuss them, whereas men often process decisions internally, speaking only when decisions have been made. I discuss these differences in my consultations with couples to hopefully avoid or lessen future misinterpretations of their unique coping styles. One alleged unethical fertility center certainly made the headlines in recent years. As a consumer advocate, I'm very concerned about this vulnerable population being misled by a deceitful infertility center. However, I think that this incident may have left the public and news media with the perception that more regulation of infertility centers is needed. As an industry insider, I'd like to inform you of the regulations already in place. The American Society for Reproductive Medicine formed the Society for Assisted Reproductive Technology, or SART, as the watchdog organization. To maintain SART membership, the embryology laboratory, the egg lab where eggs and sperm are put together for like in vitro fertilization procedures, are regulated by the Department of Health and Human Services and the Healthcare Finance Administration under the Clinical Laboratory Improvement Act of 1988, or CLIA, as well as state health agencies. The Federal Trade Commission regulates art advertising. Annual reporting of success rates is required by the Fertility Clinic Success Rate Certification Act of 1992, or the Wyden Bill, and this was published for the first time on the internet in December 1997 by the joint efforts of the CDC, Resolve, SART, and ASRM. Since 1989, SART programs have voluntarily reported their clinic pregnancy rates. And SART members must also agree to on-site validation inspections of their data as it's reported to the CDC. Obviously, couples are encouraged to pursue ART procedures from a center with current SART membership. SART reports pregnancy only after a gestational sac has been visualized on an ultrasound. Our IVF program is very successful with a 50% pregnancy rate for women under 40 years of age since 1997. We made some major changes kind of in our protocol recipe, and I think the major change was we got a different embryologist. We impose a limit on the number of embryos to be returned to the uterus depending on the woman's age, as we are very concerned about limiting the possibility of a multiple gestation pregnancy. We have chosen not to participate in surrogacy arrangements. And again, I think the old adage of that the prevention is where we want to really focus our attention. Centers do have that position of deciding which procedures they are not going to be involved in, and also of limiting number of embryos that are placed. In closing, some Christian friends have questioned how I can morally, ethically, spiritually work at our office. The multitude of moral and ethical issues is truly mind and soul boggling. I feel Christ has called us to minister to the hurting, to bind up the wounds of the brokenhearted. I think he has called me to serve on the margin. He has called me to be a Christian voice on the ethics in our office. He has called me to be a voice of faith, an instrument of peace, to speak into our patients' often confused and lonely times in their lives. As you all are aware and know, it is often during these times of